Hi, my name is Afsar Ali, and this will be a new series of ophthalmology, and I will be talking about tips on how to diagnose nerve palsies. Many of the newly qualified clinicians sometimes struggle with patients who complain about diplopia. It could be quite confusing for them to ascertain whether the patient is third, fourth, or even sixth nerve palsy. Therefore, I will deliver advice on how to ameliorate the situation. Furthermore, I will discuss conservative management as well as further management and investigation that are required. Think of your investigation like collecting jigsaw pieces in order to form a picture. And the two largest jigsaw pieces that you can obtain are taking history and the Hess chart. Often when I teach junior doctors, I tell them that if they take the history alone and they take a good history, it's enough sometimes to lead to a diagnosis. Clinicians usually follow a standard order of investigation, leaving the Hess chart towards the end or perhaps towards the middle. Who says that order needs to be followed? I suggest that it would be more pragmatic if we did the history and then the Hess chart, because you really want the largest jigsaw pieces of the puzzle to make it easier for yourself to get to the diagnosis and reach the diagnosis. The benefit of taking history is that the patient will give you key information that will lead to the diagnosis. For example, the patient may tell you that the diplopia is horizontal, in which case you can eliminate that this could be a third or a fourth nerve palsy. Moreover, the patterns between a third, fourth and a sixth nerve are very unique, and it's easier to see that in a Hess chart than ocular movements. If you imagine that this is my left eye, this would be my lateral rectus muscle, which controls the eye moving outwards. This would be the medial rectus muscle controlling the eye moving inwards. If a patient complained of horizontal diplopia, then that usually means sixth nerve palsy. The sixth nerve palsy controls the lateral rectus muscle, which is their outer muscle, making a person look towards the distance. Hence, if the sixth nerve was damaged, I would anticipate that the patient would only notice diplopia in the distance. It is subsequently imperative to ask the patient if they're experiencing diplopia only in the distance. You will sometimes hear typical answers like when they're driving, they can see two cars on the road. I am going to give you an example of a double vision patient, and we're going to walk through it step by step. And this is my patient. This is a 76-year-old cat who 3 days ago experienced double vision, walked into the A&E. The A&E doctor contacted me and told me there's a patient complaining of double vision, thinking about third, fourth and sixth nerve palsy. I've asked this cat about the double vision, and she told me that it's a horizontal double vision, particularly in the distance. So at least now I can identify that this is not a third or a fourth nerve palsy. So this is a Hess chart, and this is one of the most imperative pieces of instrument for an orthoptist who is trying to identify a third from a fourth from a sixth. So when my cat is doing a Hess chart, if she's got a left sixth nerve palsy, one of the greatest problem is when she's putting her a stick pointing to the diamonds, she'll actually be a little bit short. She'll only get as far as here or here. And a left sixth nerve palsy should show a pattern where it is a little bit short of the diamond. Have a look at the field here. This is a right sixth nerve palsy Hess chart. You can see restriction of right abduction. If you have a look at a normal field, this is what a normal field looks like. It's a full field. However, if you go back to the right sixth nerve palsy, looking at the right hand side, it doesn't quite reach fully to the right side. So when the patient's sitting down, what you should do is a cover test. When they're looking at an object for near, there will be no movements, absolutely no movements. But as soon as they look into the distance, you should see either a left esotropia or a right esotropia, depending on what kind of, depending on whether it's a left sixth nerve palsy or a right sixth nerve palsy. So at some point in the investigation, you should be doing, once you've identified if it's a right sixth nerve palsy, what you want to do is measure the angle of the squint. You use a prism bar, measure the angle of the squint like that. Once you've measured, for example, if it is a 10 diopters, what you do, you then try to join the double vision using the prism bar again. So you ask the patient to look into the distance, and slowly you join the prism like that, and join the double vision. As soon as you've joined it, you work out what number that was. You have Fresnel prisms here, and you take out the Fresnel prisms respectively to the number that you found on the prism bar. You use, now in our hospital we actually have plano lenses for the patients, so I'm going to use one of those. You put those on and then get the patient to wear it again. There you go. So I'll get my cat to wear it here. There. The cat then would tell me that she is happy with that. There's no double vision at all. You're happy? Very good. Thank you very much. And then we cut around it. Once we cut around it, we stick it on and we see the cat in 4 weeks' time. Is that good? Yeah. We have Omar. He's the ophthalmology registrar, and he will give us vital information on the possible causes to a sixth-nerve palsy. Omar, over to you.
So generally speaking, we are, as you mentioned after, that diplopia can also be managed like for the symptoms relief, but we need to dig deep inside to look for if it's an early sign of something serious happening or going there. So history for sure is very important and crucial in such situations, just to rule out any history of trauma, even it is a very minor trauma, because the sixth nerve is one of the most delicate nerves and can be easily injured with the trauma. Also, scanning is very important, especially MRI, because it really clears and it makes everything obvious for us as a soft tissue, to rule out trauma, to rule out tumor, to rule out any kind of inflammatory problems like MS, multiple sclerosis. So this is really important. Also, something related to the diabetic retinopathy. This is also important to rule out, because with the changes of the diabetes level and some inflammation to the nerves can cause a picture similar to the abducent nerve paresis. So all are important, not only to deal with the situation superficially, we need to dig deep inside.
Brilliant. Thank you very much, Omar.
Very welcome.
So just to summarize, try and stratify your investigation with history initially. This will give you a big clue, followed by Hess chart, which will show you unique patterns. And that way, it makes it easier and paves the way for you to do your subsequent investigation. And to summarize what Omar mentioned, this could possibly be a trauma. In many cases, this could be from elevated pressure because of the way the sixth nerve travels from the pons all the way to the lateral rectus muscle. This could also be a stroke or an inflammation of the nerve, for instance, after a vaccination or a brain tumor. So it is imperative to request a scan and blood tests. I hope you've enjoyed watching the video. Thank you, and please subscribe.